So welcome everybody to our event, The Truth About Heroin in Stoughton. This is sponsored by the Oasis Coalition, and we are very happy to have you all here tonight. I want to say a special shout out and thanks to the Chamber and Stop and Shop for providing refreshments for us tonight. That was very generous and we appreciate it. I'm sure everybody in the audience appreciates that as well. So my name is Stephanie Patton. I'm the prevention coordinator for the Oasis Coalition. I'm going to let my two panelists introduce themselves, and then we are going to get started. So,
good evening. My name is Jay McNamara. I'm a lieutenant with the Stoughton Fire Department.
Hi, I'm Heather Kennedy. I'm the program director of BAMSI's COPE Center. It is for the nasal Narcan pilot site in this part of the state.
Great, thank you. So what we thought we would do tonight is we are going to share with you some information and some facts, some things that we know about what's going on around the heroin issue in the state and then specifically locally in Stoughton. And then we would love to take as many questions as people have. So we're going to throw some stuff out at you, and then we will, at the end, stay as long as we need to and answer questions from there. So just to get us started. Just a little brief information about Oasis. Oasis has been around for 10 years. We are a substance abuse prevention coalition here in Stoughton. We are comprised of lots of folks from the Stoughton community representing many different disciplines and departments, including police, fire, the Chamber of Commerce, the District Attorney's Office, the schools, local businesses, parents, kind of you name it. Hopefully they have some sort of representation on our coalition, and we're always looking for more interested folks who are interested in doing that with us and doing our work. We've been around for over 10 years. We are fortunate enough to have a federal grant, a sizable federal grant, to do this work from the Substance Abuse Mental Health Services Administration, also known as SAMHSA. It's a Drug-Free Communities Grant. We are in year 9 of 10 years of funding. So when that grant expires, we will be looking for other ways to continue to sustain our work. So that is a little bit about who we are. Our focus really is around youth prevention. So I'm going to talk a little bit tonight specifically about where this issue fits into what's happening with our young people and why Oasis has kind of taken this on, because what you're going to hear is actually this is really not a youth issue in Stoughton, which is also true in a lot of other places, but we want to keep it that way, and we want to keep our young people safe. So, all right, so I'm going to hand it off to Heather for a little bit of information about what's happening in Massachusetts.
Okay, so Massachusetts is sort of placed really strategically on the map for sort of right up the Route 95 corridor. So our drug of choice in this general part of the country is definitely heroin or opiates. Other parts of the country, methamphetamine. We never really had that wave come across the country that we were sort of waiting for 5-8 years ago. But we are literally right up the corridor from where a lot of the drug cartels are working with. Stuff comes off the coast, comes straight up Route 95, literally in the back of great big 18-wheelers. Usually it goes up to Lawrence and gets distributed from there. So that's really what we're looking at. And unfortunately, based on where we're at, we have actually seen more deaths than just about anywhere else in the country at this point. There are different types of drugs that are going on for opiates in the country, but generally for heroin, we've got that kind of covered for the country. Is this one still me?
Yeah, you don't need to.
So this was definitely recently in the news, and I'm sure people have seen this. I had the privilege of sitting in a panel in West Bridgewater the day after this came out, and West Bridgewater was number 2 on the list. And I did a lot of digging, right, but like literally the night before this panel to find out what these numbers mean, because it didn't make any sense. And for starters, there's no useful information that you can gauge from this number, except it draws attention to the issue that it is not just an urban issue. It is all over the state. So what this number really means is per 100,000 residents, I'm not sure exactly how many Stoughton has, but it's not 100,000. Stoughton is ranked number 20. So West Bridgewater maybe has like 7,000, and they were ranked number 2. So we're talking actually really small numbers. One death either way could really have skewed the whole scale when it comes to what this number means. This number also represents the number of Stoughton residents based on last zip code on record at the time of death. So it's not necessarily the folks who died in Stoughton. It is based on what their last zip code was.
So this slide is data that Stephanie and I we've been basically working together since about 2011, fair to say, with the fire department's statistics. What you see here is how many times we basically administered Narcan in various ways. The Stoughton Fire Department can administer it, the paramedics can administer it multiple ways. Currently, the police department is administering it nasally. But dating back to 2010, you can see our numbers. We basically gave it 32 times in 2010. And it stayed fairly consistent, give or take a couple over the years. As you can see, up until 2015, we currently have 18. We administered it 18 times, and it seems to be going up. But as Stephanie can tell you, sometimes we have 10 in 1 month, and the next month we have 1 or none. I would imagine we'll probably stay on course to have the same average numbers throughout the year here.
All right, so this is one of my favorite slides. I do some work with the DEA when it comes to drug takebacks, and I'm always looking for the end-all be-all chart of what are opiates. I want pictures of things. Parents want to know what to look for. And basically the answer I got was there are so many different variations of potency and generic things and brand name things that it virtually is impossible to come up with an actual list. But it's important to know that some of them are synthetic, some of them are semi-synthetic, and some of them are naturally occurring. So it might come up later, but opioids is sort of an umbrella term for anything that's either synthetic or naturally occurring. An opiate is anything that's naturally occurring. So morphine, anything that comes directly from the opium poppy.
Sure, yeah, I can briefly talk about this. So what is an opiate overdose? Basically, an opiate is a central nervous system depressant. And in simple terms, the central nervous system controls our breathing and our heart rate. So if someone does consume an opiate, it can slow those two things. And specifically, what's concerning for us is the breathing at the time. It can either completely stop someone's breathing, and these receptors that the opiates bind to, once a person, I think if you go to the next slide, it shows you once a person is administered Narcan, that's nasally, that's in a nasal administration right there. Those receptors that the opioids were adhered to are now kind of bumped off by the Narcan. The Narcan has a higher affinity to bind to those receptors as opposed to the opiate. And that, in turn, reverses the overdose and restores the breathing.
That's a picture of nasal Narcan. That's bystander Narcan, and it's also what the police departments are carrying. The dosage is a little bit higher on the intranasal because you absorb about 4% of it, as opposed to what you'd have in an injection form or an intramuscular shot. But this is what bystanders can carry. And somebody's not breathing, they're not breathing it in. It lines the nose and it absorbs into the bloodstream. Okay, so treatment admissions. What I did when we were pulling this together tonight, I pulled some data from the department and came up with what the treatment admissions were for fiscal year 2014. So that's really July 1st, 2013 through June 30th, 2014. And Stoughton had 338 treatment admissions to licensed or funded Bureau of Substance Abuse Services treatment programs. And I think this number, I liked this data because it was a little bit more representative of what really is happening in Stoughton rather than this number 20 in the state. We really are talking 338 treatment admissions in a 12-month period compared to the 85,000 throughout the state. And through that data, I was able to take a look at, Stoughton is pretty right on the mark when it comes to what the state's doing, the rest of the way. We're looking at folks whose primary drug of choice is heroin, and generally speaking, all other opiates, in other words, the pills, fentanyl by lollipop or transdermal patch is actually down. Vicodin, Percocet, those are not people's drugs of choice by the time they're hitting treatment. And that mirrors what's happening statewide. And we're also looking at, it's not a youth problem. Stoughton had not fewer than 5%, but fewer than 5 treatment admissions that were under 18. We're really talking about more than 50% of folks are over 30 who are entering treatment.
Okay. Excellent. All right. And we're going to make sure we have lots of time for people to ask questions at the end, and we can go back to any slides that people have specific questions about. So I want to talk a little bit about Oasis as a coalition and the kind of work that we're doing. So what you've been hearing about so far is really Stoughton's response and what the sort of what the issue looks like around opiate overdose, which is unfortunately sort of the last very bad consequence of opiate use and heroin use. So that is a place as a community that we really are hoping to never have to deal with. Unfortunately, we do have to deal with it. And so as a result, we've put together a really great program with the police and the fire department to make sure all of our first responders have the ability to respond in an emergency situation with nasal Narcan, which is the antidote to an opiate overdose. So that's terrific. As a coalition, we really helped put that together because we felt like we were facing a public health emergency, and a large part of our work is about collaboration and bringing people together. We had all the folks in the room to help bring that to fruition. But really, most of our work happens in the primary prevention realm, which means really trying to prevent people from using any of these drugs at all. So not just heroin and not just other synthetic opiates and the pills and stuff, but any drugs. So, we don't want our young people drinking alcohol, we don't want them using marijuana, and we certainly don't want them progressing to heroin and ultimately being in a situation where they might be overdosing. So a lot of the work as a coalition that we do is we try to think about what are the things that put folks at risk and reduce those risk factors so that people never end up in this pipeline that can lead to an overdose. So I want to talk a little bit about that and what we know locally. So one of the things I like to think about is I think about our work almost as sort of a river. So when we think about overdoses and preventing overdoses, that's sort of a treatment. So that's the ambulance. That's somebody's fallen in the river and we need to rescue them and pull them out, which we absolutely need to be doing. We can't be letting people drown in the river. That's not okay. So because we care about folks and we are a community, we make sure we have stuff in place down the river to be pulling people out. Our goal is for people to never get in the river in the first place. So we need to be thinking about stuff sort of along the way. So we think about interventions as well. So people who are maybe floundering in the water, I think about a lifeguard, somebody who's there trying to make things safer for folks who might be in the river. So these might be kids who are using substances, and our goal is to try to prevent them from moving on to heroin or to prevent an overdose from happening and not have to reverse it, but maybe, keeping things safer. But the place where that Oasis actually does most of our work is actually way upstream. So primary prevention, and that means really trying to prevent people from falling in the river in the first place. And a lot of our work as a coalition has really been to try to focus around making the river essentially less attractive for young people. So if it looks like it's a fun place to go, no matter how much we teach people, don't go in the river, it's not a good idea, it's not going to be enough if it seems like it's a really fun thing to do. So as long as drugs and alcohol continue to be really attractive to young people, and the media is doing a very good job with that, we need to be thinking not just about how do we counteract those messages, but also how do we safeguard our kids? How do we build fences, basically, to prevent them from doing these things? And so I'm going to talk a little bit about the stuff that we're doing in that domain as well. But I want to share with you a little bit also about what we know about the problem. So as we think about how people end up using heroin, there are several pathways to heroin use. One of the things that I like to think about is addiction as a developmental disease, because when kids start experimenting with drugs, any drug, when they are younger, they are much more likely to develop problems with addiction or have other consequences later in life. That's what the research says. Kids, their brains are developing until they're in their mid-20s. So when your brain is changing all the time, when you use substances that also have the effect of changing your brain, you could be changing it permanently, and you can also be setting up the structure so that they're more conducive to set you up for risk of addiction later on. So, when we think about things like marijuana use, Youth exposure to marijuana, this is a good example, can prime the brain for addiction to opiates later on in life. It's those same neural pathways in the brain that if you're a young person and you're experimenting with other drugs and your body is, kind of getting the message as it's developing that because it's stimulating all these reward centers, later on, if you are prescribed a painkiller, you might respond to that differently than somebody who hasn't had that experience. So early prevention and preventing other drug use is actually a really important piece to all of this work if we really want to reduce the number of overdoses in the future. Because we don't want to have to keep, it's really great that we have Narcan in place. We don't want to have to keep doing that. Our goal is to not ever have to use Narcan. We want to have it in an emergency. We don't want to have to use it. So, when we think about kids and some of the top reasons kids use prescription drugs, which is another pathway for kids to get involved with heroin particularly, or some of these other painkiller drugs, the number one reason that kids talk about using prescription drugs is they're easy to get. They're easy to get from their parents' medicine cabinets. This is the same issue we see with all their drug prevention. When it's easy to get alcohol, when it's easy to get marijuana, when things are easy, kids will do that. And, when you think about the developing adolescent brain, the part of the brain that basically tells you, all of us as adults, like, maybe I should stop and think about that. That might not be a good idea to put that in my mouth. That isn't entirely developed in kids. And so as adults, we need to be the brake for kids. So if it's easy to get something and they can do it before their brain can catch up and say like, oh, that was a bad idea, then sometimes these decisions are made and it's already too late. And so sometimes if you have a teenager in your house and they say to you, I have no idea why they did that, they honestly really might have no idea why they did that. They're not trying to be fresh. It's sort of part of development. So we need to think about that. So making it harder for kids to get these things, like drugs in the medicine cabinet, is something that's important. Kids get the message that, prescription drugs, they're not illegal because in a lot of cases they're prescribed to somebody. So that it sends the message that it must somehow be safer in some way. If a doctor is going to prescribe this to you, then maybe it's safer to use. Now, certainly, getting something that's prescribed to you is very different than taking it recreationally. So, but that's a distinction that is not as clear. In some cases, these things are cheap, kids tell us. Certainly, heroin is very inexpensive, and that's one of the reasons why we see people who end up being addicted to painkillers progressing to heroin. They can't continue to have a habit that's so expensive, and heroin, unfortunately, is very cheap on the streets. They feel like it's safer to use, and they feel like their parents don't care as much if they get caught with prescription pills than some other drug. Now, these are kids' perceptions. That doesn't mean that that's true, but that's what kids believe. This is sort of also related. Nationally, kids report that during the last conversations they had with their parents about alcohol and other drugs, in most cases the parent talked about alcohol, they talked about marijuana, they didn't talk about prescription drugs for whatever reason. Maybe they didn't know how, maybe it didn't occur to them that this could be a problem. So they're having some of these other conversations, but not about the prescription drugs. And again, that unfortunately kids who do misuse prescription drugs, a lot of them are getting it right out of their parents' medicine cabinets. So one of the things we've done is in Stoughton, we actually did a parent survey. So I can tell you a little bit about what our parents think, especially compared to our young people. So this chart shows in terms of perception of risk of prescription drug use. This data is from 2013, so it lines up better with the parent data. This hasn't changed significantly in our most recent survey with our young people, but most kids, 63% of them, believe that there is great risk to using prescription drugs recreationally. That's really great. Another quarter of them believe that there is moderate risk, so that we want to see. And we know that also our parents believe that there's great risk to using these things as a child, so that's also really good. About half of the parents that we surveyed said they talked to their child at least several times a month about alcohol and other drugs, which is great. So ATOD is alcohol, tobacco, and other drugs. And we learned that almost every parent would be extremely concerned if they learned that their child was abusing prescription drugs. We also know that parents are the single most important factor in actually preventing a lot of this use from happening. So even if you don't believe it, if you're a parent of a young person, you think your child is not listening to you, they are listening to you. The messages are getting in there, as long as you say them, and that's really important. And we have some resources from Oasis and the Youth Commission out in the hall actually about how to have those conversations, and we're happy to answer questions about that. We know it's a tough conversation to be having and to have over and over again, but it is very important. It is one of the best prevention strategies we have is parents talking to their kids and being clear about their feelings about using drugs and the consequences. So this is some of our newest data from Stoughton High School from 2015. So we ask students a lot of questions about alcohol and other drug use. It's really important to us to understand what's happening. And what we know, this little teeny tiny bar here, the 0.7% is what students are reporting around heroin use. So that is only a handful of students. I meant to do the math today and I didn't get a chance to. But these are students who report that they have ever used one of these drugs. So 49.8% of students at Stoughton High said they have ever had alcohol in their lifetime, more than just a sip. 36% marijuana use in their lifetime, and then it sort of goes down from there. So as you can see, our heroin problem in the scale of things is very, very tiny, and it's actually, I can share with you. Yeah, that is not the one I wanted. Okay, clearly this didn't go in the order I wanted. It's been going down since 2009. So that number, even in 2009, was small. Any heroin use, of course, we're concerned about that. So I don't want to minimize that 0.7% of students that are using. But the good news is that in the scheme of some of the other things that we're seeing, this is not a young person's problem. It is, you know, as you hear about some of our overdose data, it is a problem with our adults who are in their 20s and 30s. And you know, and these were folks who were once in high school and maybe, you know, potentially experimenting with other drugs and doing some of these other things that we need to be paying attention to. So I do want to go back for a second. So a few other things that we know about drug use and our students. So this is a chart that's probably very confusing and hard to read, but it's showing the relationship between students who use a particular drug, which is the drugs in the left-hand column, and what other drugs they might be using. So you can see that students who report that they use prescription drugs, most of them report that they also drink alcohol, most of them report that they use marijuana, and then some of them are reporting cigarettes and cigars. So it's not something that students are using exclusively. It's usually when students are using prescription drugs, and they tell us this at the high school when we do focus groups, that of those students, they're using other things as well. So this isn't an isolated issue. It's related to other drug use, which is why we talk about all these things together when we talk about prevention. The other piece of information that I think is really interesting is when we ask students about what's actually happening at the high school based on what they tell us and what they believe is happening. And so this is data about sort of the gap between what students believe and what is the truth. And this is really important information because when there is a big gap between what's actually happening and what people believe, it actually creates risk for students. So what we can see for prescription drugs here is that only 3% of our student population reported that in the month prior to the survey, they had experimented or used prescription drugs recreationally. But what they believe is that more than half of their peers are doing that behavior. So what happens is it creates almost a false pressure or a false norm that this is what is typical at Stoughton High, and it's not true. And so we need to be, as parents, as community members, really reminding our kids that if they're engaged in this behavior, this is not typical. This is not normal behavior for Stoughton students. Most of our students are not using drugs and alcohol, and most of our students make really great, healthy choices. And so we want people to be part of that most, and not reinforcing any false beliefs that, you know, don't follow the crowd because they're all doing drugs. They're not. The crowd is actually not doing that. So we want to make sure we aren't inadvertently sharing those messages. Okay, we did that. The other thing we talked about is about whether or not things are easy to get for students. And so, you know, the good news is we know that compared to other drugs, students report that it is relatively more difficult for them to access prescription drugs than other things. So this is data from both the high school and the middle school. So that's important. Could that number be lower? Absolutely. And so that's one of those things that, you know, we need everybody's help to make it more difficult. This is also a perception. It doesn't mean that 45% of students are getting prescription drugs. It means that when we ask them if they thought it would be easy, even if they've never tried, that's their feeling about it. But again, their perceptions, that's their world, and so that's really important because it speaks to, you know, what they think about the issue. So I want to tell you a little bit about what we're doing about some of these things, and then I'm going to stop and just take questions. So So we're doing a number of things. So I talked about how important it was to reduce particularly young people's ability to access prescription drugs. As a coalition, we can't do a whole lot about reducing access to heroin per se. That is a police issue, and our police are doing a lot of work in that domain, and we collaborate with them a lot around all of these things. But we do have a number of things in place in Stoughton to help families get prescription medication that is unused and sort of excess out of their homes. So we have a drop box at the police station. It is in the lobby. It looks like a big mailbox. You don't have to talk to anybody. You can go in, open the slot, throw your stuff in, and leave. It's really that simple. It's anonymous. The stuff gets incinerated by the police department whenever the box gets full in a safe way. It's safe for the environment, and it's really the safest and easiest way to get rid of any of that extra stuff. But we also host with the town on Hazardous Waste Day twice a year. We do prescription drug take-back days. So I would encourage people to not wait and hoard things for those dates. But if the date happens to be coming up and you want to come and see us and get rid of the prescription medication in a way that's also safe, we're happy to take them at that point. We've done some mobile take-backs with seniors who maybe have some issues where it's challenging for them to get out of senior housing. And so we've gone around with the VNA and the police and a pharmacist and collected medication from folks in community rooms. We've been doing a lot of work with pharmacies and our local pharmacists trying to address this issue and really encouraging them to be using something called the prescription monitoring system, which helps identify when people are trying to sort of shop doctors and get excess medication. So, that's a role that a pharmacist can play. And then the coalition, through collaborations we have with other entities, is also trying to do some work around prescribing practices, because there is a lot of overprescribing that sometimes happens. And when people end up with too much of something and they think that their doctor's recommendation is, well, if I gave you 30 Percocets, you should take them all, which isn't usually the case, but a lot of times those conversations aren't happening. So, looking at some policies around limiting some of those types of prescribing practices that can sometimes inadvertently either create excess medication or can lead to addiction if somebody takes it all. This is just we did a survey with Stoughton pharmacies. The number about having policies about checking the PMP, which is the prescription monitoring program, was from 2014. I believe the last time we went out, I would say that number is closer to 100%, that they all now have policies, and the state has done a lot of work with that. And some of our pharmacies are accessing that system a lot. It depends on how many prescriptions they're filling and the types of scripts that they're filling. We're also trying to do some work with students around promoting those positive norms, reducing those misperceptions, providing information and skills for parents. We do a lot of work with the parent liaisons and offer programming. We have materials that we've developed that are available both on our website, and some are in hard copy, but videos and other types of things. We've done some education for seniors, and we've been doing some community education at some of the pharmacies through cards around safe disposal, so that at that point of picking up a prescription, the individual who's picking up their script gets a little reminder about, if you have extra of this stuff at the end, here's how you can safely get rid of it, because not everybody has that information. And that is in addition to the work that people really probably have been hearing a lot about, which is this piece about Narcan, which you heard both Jay and Heather talk about in the beginning. And so Stoughton is really fortunate. We were the first community to independently equip our police department with nasal Narcan, nasal naloxone, which is the antidote to an opiate overdose, outside of what the Department of Public Health was doing as a pilot project. So it was work that took a lot of collaborations, a lot of people. It had a lot of moving parts. It sort of looked really easy from the outside. It was not quite that easy from behind the scenes, but it's been a really successful program. The police department has been carrying Narcan for 1.5 years now, I believe, has had a number of saves. Oftentimes, they are the responders, because they're in their cruisers and they're out on the street. They're often there before sometimes the ambulance can get there, and that minute or 90 seconds between that and the ambulance arrival can be really critical time for a family or for an individual who's not breathing. So it's been really, really important, and it's been a great tool for us to be able to have the police do that while they are waiting for the ambulance to come and to sort of pick up the medical care from there and then transport the person to the hospital. You have a question in the back.
Yes, maybe mention on Narcan, if what the effects are if it's administered to somebody
who doesn't need it. Yep. So actually, I'm going to let Jay answer that, because I've been talking for too long.
I will refer to what our medical director, Dr. Dan Muse, who was basically kind of collaborated this whole thing, got the whole thing going for us, for the town of Stoughton. He basically says there's really no effect. If you gave it to somebody who didn't need it, it's going to have absolutely zero effect on them. So when in doubt, we administer it, or a family member could administer it and have really no worries or concerns.
It would be like saline to any one of us who didn't have opiates in our system.
How could family members get it?
I'll have to.
I'm going to give it to Heather.
You can see me when we're done. As part of the nasal Narcan pilot site pilot program, there's a few different avenues you can go about doing that. Local pharmacies, Walgreens and CVS, both have standing orders through my medical director, which is Alex Wally, and through the Department of Public Health. So you can go in and have a prescription filled, that the prescription's already there waiting, and you just have to go in and have it filled. It'll be the copay for whatever your insurance would be. For Mass Health Standard, it is free. For folks who need nasal Narcan, it's often because you have a family member suffering, and often financial concerns come into play, and it can be very expensive. And we're able to provide it for free through the pilot program, which is basically a big research study. You can also pick it up at a Learn to Cope meeting, which is also part of the pilot program. So any Learn to Cope meeting would have it also.
Will you tell them what Learn to Cope is?
Learn to Cope is a parent support group for folks who have a loved one who is suffering primarily from opiate addiction, but basically from any substance abuse addiction. The question was, do we give out nasal naloxone or like intramuscular naloxone? We give out nasal. If you go to the pharmacy, you can actually get it. The standing order is for intramuscular or intranasal. Lots of programs that do what I do around the country actually do intramuscular, which is the shot, like a muscle shot, like a flu shot, basically. But we will give out nasal.
Yep. Okay, so the question is, what is our role as community members if we are worried about somebody where there might be addiction? So when we go back, think about that river slide, basically, now we're the lifeguard, right? Because somebody is struggling in the river. I'm going to ask Heather to answer that.
So I think there are a lot of different signs and symptoms for addiction. It's basically folks with opiate addiction specifically, it's a behavior pattern. So we're looking at the bystanders. If you do have somebody who's a loved one, get some support right away for yourself, because the real answer is you can help offer resources, you can help sort of with a stigma piece and say, I love you, I don't love what you're doing, or I see you're struggling. I'd say, you know, call it like you see it and offer some support, because for folks suffering with addiction, it really is a neurological condition, like a behavior pattern, where if they're really caught up, they're not going to be able to stop on a dime. And I think it's going to be a long process in which you would need some support for yourself to be able to help them get through that process. And the best thing we can do is help them get ready to ask for help, and then making sure that we can get the help available to them when they're ready to ask for help. And I think it makes it really challenging to sort of address that without getting into real specific circumstances. Everybody has their different scenarios at home, whether it's you have somebody living in the home or you're working with somebody. Everything pops out at some point behaviorally, and looking for signs and symptoms. If it's within your home, I'd say look for things that are missing, look for money missing, look for weird sleeping patterns, if any. What we know about opiate addiction is it's generally something that they're going to take a fix on 3 or 4, maybe 5 times a day. So it's just making sure that we're not putting them at risk for overdosing or having a fatal overdose, because we won't talk about what's going on. Does that help? Or
I think the other way to think about that question, if we think about ourselves as a community, is that in order for the conditions that Heather is talking about to also be possible for people, we need to think about the way we talk and speak about addiction and about overdose, and we need to be reducing stigma and some of the barriers that exist for people about being able to ask for help, because there's a lot of shame with addiction. And so, you know, if we think about it more as a chronic disease, and we think about it as basically, you know, if you're somebody who is addicted to an opiate, you really have significant changes in your brain that are currently happening and that are impacting your behavior. So it's hard for those of us who are not struggling with opiate addiction to even understand or to think about why people make certain decisions that they make when they're in the throes of that, because it doesn't necessarily make sense, because people are seeking out more of the thing that had sort of changed their brain in the first place. So as a community, we need to be really thinking about these are our family members, these are our friends, these are our neighbors, these are people that we care about. We want to take care of them, and we want to be able to have things in place when people are ready, and we don't want to be judgmental when folks ask for help. And so I think trying to get that message across goes a long way for the ability for people to ask for help. I think some of the work that we're doing, one of the reasons that I particularly like the having the police carry Narcan, since the slide is still up there, is again, it sends that message that we are a caring community. We're taking steps to do everything we can to protect all of our community members, and we're not judging. This is a medical situation, and we're going to deal with it as a medical situation, and we want you around so that when you're ready to ask for help, you're going to be able to be here to get it. Yeah. Yep. So the question was about neighboring communities, and you were using the example of Canton, where recently they had maybe a few overdoses in a particular week. One of them was fatal, and that their police chief was talking about that heroin seemed stronger. So I don't know if either one of you want to talk about that.
I answer this question on a regular basis. This comes up all the time, and I think what we're seeing on the street, I get drug data from the state police on a regular basis, and basically tells me what is in the drugs that are out on the street. And oftentimes they're the ones, well, every single time they're the ones responding to an unattended death, a death that happened from an overdose that wasn't at a hospital. Somebody didn't make it to the hospital. So I get a lot of that information, and a lot of what we're seeing, not necessarily specific to that one fatality that you were talking about, but a lot of what we're seeing is really, really potent heroin, or we're seeing like 90% pure, as opposed to what was maybe happening, 15, 20 years ago. It was down closer to 20% pure. And the problem is it fluctuates wildly. The other piece we're seeing is that we're having an awful lot of stuff that's coming in that's actually fentanyl. Fentanyl is synthetically made. It doesn't need a growing season. So with a lot of the drug dealers or big-time drug traffickers are trafficking in large quantities of synthetically made fentanyl, and it takes about a pinhead's worth of fentanyl to equal what a bag of dope would do. So, unfortunately, if you're buying a bag of dope, you think it's dope or heroin. You don't necessarily know which shot in there is going to have the fentanyl in it, but one of those shots is going to have a whole lot of fentanyl in it, and the rest of it's going to be whatever they're using to cut the heroin with. So it might not have any effect or really little effect at all. Does that answer?
Jay, do you want to talk about how that plays out, like with the ambulance and the Narcan doses and stuff?
As far as how many?
Yeah, like that sometimes you have to use more. Or
We do. We're able to administer anywhere between, say, 0.4 milligrams to up into 2 milligrams of Narcan for any given patient. And we can get doctor's orders, physician's orders to give more and such if we had to. Right. But it can fluctuate. We tend to start on the lower end, and then if we need to give more, we do. So I was going to say we tend to see some overdoses too when people, they're mixing it and cutting it with other things. But also I think when people maybe get off it or go to rehab, and I don't know if you ever, correct me if I'm wrong, but a lot of times people who they leave off doing a certain amount of the drug, and they try to pick back up where they left off, and a lot of times that leads to an overdose. So they kind of, had worked up to a certain amount of the drug and then have been off it for some time, and then pick right back up to that dose, and it can be fatal for them at times.
right. Yeah.
I literally do a 2-hour class on this, and I will try to refrain. But I know that, what was I specifically going to say? Oh, it's also, oftentimes we see when it comes to mixing drugs, people compulsively use opiates in pretty much the same way every single time. Some people always mix the same drugs together, and it can potentially be fatal because most of the drugs they're mixing are drugs of tolerance. So you need more just to get the same effect that you did like the week before. But what we're also seeing is, generally speaking, when there's a big drug bust or a big drug dealer picked up off the street, we see a lot of folks who have a physical dependency to these drugs who are compulsively, running to chase the high that they're looking for, but they're also obsessively avoiding the withdrawal symptoms. So they're doing whatever it takes to avoid the withdrawal symptoms. So they might take a little bit of this, 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 and then their drug dealer finally comes through. You know, that maybe the streets have calmed down a little bit and they can finally get a hold of some heroin, which they know will make them feel better. And then they'll do that, and then they'll overdose. So that we see a lot of, or hear a lot more of that too. And I think a lot of it is challenging they don't necessarily understand what the drugs they're taking are going to do, but they know how physically sick they feel. I mean, we talk to a lot of folks who literally can't even get out of bed, but without actually having to inject some opiates before they can actually stand up. So it's a real physical reaction when they're in withdrawal, and they're compulsively avoiding or obsessively avoiding that particular feeling. So when they're often mixing drugs, it's not necessarily because that's how they would choose to use, but they're often self-medicating their withdrawal symptoms too. And then when their heroin comes through, they definitely take that. Okay, so will the Narcan work if somebody's on the methadone clinic or on the Suboxone clinic, and then they're using other drugs on top of that? The answer is yes and no. So the Narcan always sits on the same receptor in the brain that the opiates sit on, and methadone is definitely an opiate. It's one of the best used for opiate replacement therapies internationally for decades. So that it will reverse what the opiates are doing in the brain. But if they're doing anything else, oftentimes a great sort of cocktail of medications would be some benzos, short-term fast-acting anxiety medication that sort of tops off what the methadone gives you. Methadone is a maintenance drug. You don't get all that high off of it, but because it doesn't have a whole lot of potency to it, oftentimes folks will take other things on top of it to sort of enhance the high, and benzos are very common for that. So no, the methadone will be reversed by the Narcan, but the other drugs, whether it's benzos or even clonidine or whatever else is going on, will not be reversed by Narcan. It's always important to call 911. Narcan, is it safe to keep in your car, whether will extreme temperatures change its effectiveness? So the answer is yes, yes, and yes. You can keep it in your car. It is not recommended to be kept in your car. It's recommended to be kept anywhere between 59 and 86 degrees. It might become slightly less effective if it falls out of temperature range, whether it gets too cold or too hot. With that being said, we give it to folks who are living in the woods all winter long. We give it to folks who are living outside all winter long. We have folks leaving in their car all summer long. Slightly less effective is 100% better than completely not there, if that's where you need it. Does that make any sense? Should you be calling for medical attention? Absolutely. But something is better than nothing. Expired Narcan, same thing. Something is probably going to be better than nothing. And it might just be enough to get somebody to start to breathe.
I was going to say with our ambulances and our fire engines that carry medications, it's all temperature regulated, and it's kind of stay at a consistent temperature. If anybody was concerned about when our ambulance is out in a snowstorm or if it's parked in the garage and it's 0 degrees out, our medications are all temperature regulated. And I would agree that something is better than nothing, even if it was expired or left in your car for in extreme temperatures.
So the question was about 18, 19, 20-year-old students young people that are not in high school, but that are maybe just out of high school, young adults, and what do we know about heroin use or other drug use in that population? No, unfortunately, I don't have that data for Stoughton people. So the really nice thing, you want me to put the slide back? Oh, Heather does. So Heather can tell you. Well, you can tell treatment data, right? Yeah. Okay, and then I'll answer the rest of it now.
So I have, this slide was up there as far as treatment admissions go, and I wasn't sure if it was broken out, but between 18 and 25 years old for treatment admissions into licensed or funded substance abuse programs in Massachusetts, there were 23.8% of the 338 folks who entered treatment were in that age range. So with their primary drug of choice being heroin.
Right. So I think So a couple things. So one, we're really lucky that the high school is a captive audience for us, which is why we survey there, because they're stuck under the roof of a building, right? And so it's really easy for us in one fell swoop to survey all of those students. Students who are not at the high school, who maybe live in Stoughton or at colleges, unfortunately, like there's no good way for us to capture that audience. This is really good sort of proxy for at least people in that age bracket who are seeking treatment. So it gives us a sense. It's a piece of data. There are national level surveys that could tell you about that population in general. We can look at college surveys. We do know that those problems are more significant when kids are older. But as folks who are doing prevention work and sort of have, again, that captive audience, a lot of our work is with young people to try to prevent that earlier drug use so that they don't progress. Because the later they start using any drug, the less likely they are to use some of these other things. But it's a really good and it's an important question, and it's a tough one. Yeah. You have more? Yeah?
I have a little bit more.
Okay.
I pulled some stuff that we cut from the slides, and it doesn't necessarily, we don't have an exact answer for your question, but I'd have a little bit more sort of data that might help give a better picture of who we're talking about. So for Stoughton mirrors the statewide data pretty closely when it comes to employment and homeless status. So when we're talking about who entered treatment from Stoughton, we're talking about 78.3% of folks being unemployed, but 86% of folks who entered treatment were housed. So we are talking about folks who live in Stoughton who don't have jobs, and we're also talking about Stoughton education levels definitely mirrored the state also pretty closely. So 78.7% of the folks who entered treatment had completed high school or more than high school were the categories.
So the question was really sort of about the reliability of that survey data that we get from our high school population. And so kids are kids, and some kids lie on the surveys. And we know that, actually. And typically, they don't lie well enough for us to not know. So we can pull those surveys out. So every time we do the survey, some of the surveys get yanked because it would be very hard for a student to lie consistently through the survey in such a way that our evaluator wouldn't notice. Or they do something that's like so obvious, like they answer D to every question, and it's pretty clear that it would be unlikely in somebody's life that every answer to every question would be D. But the other thing that makes me feel really good about our data is that we survey every other year. Our data does change. We see trends and stuff, but it doesn't change so dramatically that it looks like things are just fluctuating all over the place and students are sort of making up whatever answers they want. The data tends to be fairly consistent. Either it's trending down, it's trending up, but not grossly. It somewhat mirrors what's happening in the state. So we are lower in most dimensions with our substance abuse data than the state, which is excellent for us. It's never low enough. Obviously, we still have a lot of work to do, but it's a close enough pattern and parallel that unless there was a statewide conspiracy and probably a national conspiracy among youth, that the data feels pretty good. And probably, some kids who are exaggerating and kids who are under-reporting, a lot of that's going to come out in the wash. But particularly with harder drugs like heroin, it's my hypothesis that if a student really was using heroin regularly, unfortunately, they probably are not going to be successfully still a student at Stoughton High School. They might be living in our community, but they're probably not able to really, be a student on a regular basis. So we might not see them in our data set anyway. So there are possibly students in this age, or young people in that age bracket who don't get picked up by the data because they are no longer students. Or, we also have a lot of Stoughton kids who go to other schools. And so we don't see that here either. Our survey is just Stoughton High School. So we also need to be aware that this doesn't represent every young person in Stoughton. It's just our best estimate. So I saw I'm going to take some other folks. Yeah, go ahead.
Stephanie, can you explain?
There is drug prevention education. I am not in the schools myself, so I don't want to misspeak for the schools. There are some evidence-based curricula that the schools use that have a drug education component to them. I think like every school district, it would be wonderful if we could do more of that. There are a lot of pressures on school systems. The coalition does a lot of collaborative work with the schools. Our work is less about direct sort of curriculum type interventions and more about looking at the policies and the sort of norms within, sort of more about school climate and what are some of those pieces that make it less likely for students to use drugs and alcohol and sort of increase their some of the things that we know is kids who feel connected to adults, caring adults, or institutions are less likely to use drugs and alcohol. So making sure the school is a safe place where kids feel like they have somebody they can talk to is really important. Also really important in their own homes or other organizations they're connected with. So that's a piece of work that we do. Reducing those misperceptions among students is a piece of work that we do. I know the school is doing a lot of work as well around sort of the climate piece, which it's a great protective factor. It's a piece of work that almost feels, it's a little bit invisible. It's hard to measure. And again, like when we're good at this stuff, we never see it. So it's like when we're successful with prevention, we don't know because the behaviors aren't happening, or they aren't happening in as much of a way as in some other cases. But we also do some work with the school around policies, and some of the schools have the chemical health policies that exist at the schools, the things that the athletes are, there are regulations for athletes particularly that are strong around drugs and alcohol prevention, which all these things are helpful for parents as well because it gives you tools to use with your kids. Even policies like not having students drive to the prom. So having every student be required to take the bus to the prom is a really great policy, and that it sort of normalizes, we're not driving on that night. It's maybe a high risk night for drinking and driving, so we're just going to take that away as an option and level the playing field. And so sometimes things that seem like really simple can be really great sort of cultural pieces around this issue. Okay, so the question was about middle school, and we didn't actually see a lot of middle school data. So with the very same survey that we use at the high school, we use at the middle school. They get all of the same questions. Part of the reason that you didn't really see any of that data here tonight is because the use rates are essentially zero. There's no heroin use at the middle school. The prescription drug use at the middle school is so tiny that even I actually question, in conversations I've had with the principal, we wonder if students entirely understand that question because they might think like, well, I took Tylenol, my mom gave it to me, and they're saying like I used prescription drugs, and so we didn't really see us report out on that. Students at the middle school also, which is no surprise developmentally, know that prescription drugs are bad. Everything to a middle school student is either good or bad. So drugs, bad, they get that. Very, very small percentages of them are experimenting with things. We want to keep it that way. And they do have a very good curricula that they use around drug prevention specifically, and we do some work with the middle school as well. Yeah.
Okay, so I brought all my paperwork today. So 57.5% of the folks who entered treatment in the data set that we're talking about, the 338 folks during that 1 year period, had prior mental health treatment. So that is the data that they were able to collect. So yes, we are talking about more than 50% of the folks who had a co-occurring disorder or had sought some sort of mental health treatment.
Not unusual.
Not unusual at all. A lot of opiate addiction mirrors compulsive behaviors and anxiety disorders. So, sure, I'll take that. So resources, how to get them, where to find them, point of entry for that sort of thing. I generally refer folks to the Learn to Cope website. The word learn, the number 2, and then the word cope.org. It literally has everything, including an interactive chat where you can get a login and you can actually talk, in real time to other parents about what's going on and what you need help for. They have probably the most extensive list of resources ever. And as Karen's pointing out, we have dozens and dozens of their, pieces of information. For when it comes to folks who are seeking treatment services for themselves, oftentimes my drop-in center is the point of access. It is in Brockton, but we do a lot of work in Stoughton also. We've been doing a lot of work in Stoughton for about the last 2 years. And we have resource directories or resource cards in the lobby that have the full detox listings, including the brand new detox that opened list just this year. It has all the phone numbers on the back. So it's sort of a one-stop shop for somebody who might be actively using, who might need a little bit of help getting ready for accessing some of those services. That's what we're there for.
So the question is if, and I'm going to say if, because this is not a done deal by a long shot. If marijuana were to become legalized in the state of Massachusetts, we do know it's going to, is likely to be appearing on the ballot in 2016. What would that change for us? Do we have things in place in terms of prevention? What might that mean for our opiate numbers? So as a prevention coalition, that's certainly an issue that we are looking at. We have a lot of information and resources around the marijuana issue in general, so we're always happy to educate folks around what is the marijuana of today? And I can tell you it is not the marijuana of 20 years ago. It's a very different drug. It's significantly stronger. A lot of the research is showing, I had that one slide that talks about how marijuana can actually, particularly in young people, it can really prime their brain for addiction. So it does, unfortunately, it can set somebody up to be at higher risk for an opiate addiction should they go down that path. So, we hear that term gateway drug a lot, and there's it's an interesting term because what is true about marijuana is there are a lot of folks, and you saw in our numbers, unfortunately it's the number 2 drug that students use. It's true everywhere. There are a lot of people that use marijuana. Of that large grouping of people, it's still not the majority, but if you sort of project that out across the country, it represents a lot of people. Of that group, some of them will progress onto harder drugs. Most of them won't, which is a good thing. There is a level of addiction with marijuana as well. For young people, it is higher than for adults. So for adults, I think it's 1 in 9 adults can end up with an addiction issue with marijuana. It's 1 in 6 for kids. So that's significant. It's something we need to be paying attention to. Addiction is addiction. It's concerning. There are a lot of issues with marijuana, and I do think it is related. It's absolutely related to this opiate issue, particularly because if you're talking about youth and kids starting and experimenting with things early, then their risk for progressing to other drugs does increase. And opiates are one of those drugs. So it's concerning. It's something we need to be looking at. We need to be looking at those links more. I think there's still a lot of research that's coming out. But it's an absolutely related issue, and we're doing a lot of marijuana prevention work, and I'm happy to talk more about that. I could go on about that for a long time, but I won't. Yeah.
So I actually do a lot of work with 15 different communities at this point, and Stoughton had brought in Dr. Kevin Hill a couple of weeks ago to talk about marijuana, and it was a remarkable presentation. And he's actually coming to Carver Middle Senior High School on the 24th of this month at 7 o'clock. If you wanted to see the presentation again, he's going to do the same talk. So I'd found that it was so impactful when I was here in Stoughton that I, as I usually do, bring some great information to a different community and have them try it there too. So they're doing the same talk that we did in Stoughton in Carver on the 24th at the high school.
And actually, to plug Stoughton Media Access, one of the things that they did for us is actually we collaborated and hosted a big event at the John F. Kennedy Library where we brought Dr. Nora Volkow, who is the head of the National Institute of Drug Abuse, to talk specifically about marijuana. And we were lucky our friends from SMAC filmed it for us. And so I know that video is available. Her piece is 30 minutes out of, all of the speakers were excellent, but she spends a lot of time talking about the science of what is today's marijuana, what does it mean, how does it affect the brain, how does it affect the adolescent brain. It's a great presentation. She's an amazing, brilliant woman, and I would encourage you to look for that. It's also, we have the link on our website and on our Facebook page. So it's a great, if you want to learn more about that issue, that's a really great place to start as well. We are in year 9 of a 10-year grant. That grant is not renewable. So one of the things that with the Drug-Free Communities grant is by year 10 we are supposed to be able to fly on our own and either seek other funding resources or figure out a way to do the work with other resources. And we are working on that. And we will be around for at least another 10 years, I promise you. Yeah.
I just wanted to point out that there are free Sharps containers in the hall, and they, in case nobody knew what they were, they are free, and you can dispose of them at the Stoughton Fire Station.
The 30 Freeman Street location. The 30 Freeman Street location.
So that is one of the things I get to do with the Department of Public Health. There's also a syringe disposal site at my drop-in center in Brockton if you happen to be driving by.
Yeah, so I will just, so I guess in closing, I just want to say thank you all for coming out tonight. I want to thank again our panelists, so both Heather and Jay from the fire department. I want to thank the Chamber and Stop and Shop for providing us with refreshments. And I want to thank SMAC for filming tonight and being able to make this available to folks at home who are not able to be here. So we absolutely appreciate that. Please stick around and ask us questions. Please partake of the resources that are out in the hall. There's lots of great stuff. Those Learn to Cope books are out there, the Sharps containers, resource cards, stuff from the Youth Commission, all kinds of things for folks of all ages that people might be interested in. So definitely take advantage of that and look for us on the web. We are on Facebook at Stoughton Oasis. Our website is www.stoughtonoasis.org. We are on Twitter. I don't entirely understand Twitter, but we're on Twitter. So if you do that, we tweet somehow. I do it. I'm not really sure how that happens, but or come stop by and visit us at the Youth Commission. So thanks for coming out, and have a great night.